Hi guys, this is Dr. Pawan and welcome to a session where we are going to talk about different tubings, different drains, different kinds of catheter, different kinds of instruments which are basically used in the general surgery. Now in this what we are going to do is we are going to show you the instruments and we are going to show you like how they are actually used in the real world. At the same time, we are also going to this is going to run in the parallel with the PPT where I will maybe write few things, maybe tell you a couple of things, and then simultaneously I'll be showing you those particular instruments as well. So let's start and hope you like this particular session. So we're going to talk about the basic surgical equipments which we use in day-to-day life. Now, no surgery is complete without a cautery. Okay, so what we want is we want a monopolar and a bipolar cautery. So that is the first thing which you need to understand over here. Okay, now this is the image of your monopolar cautery. Okay, and this is what is your cautery pad. So this is a patient plate. Okay, what is this? This is nothing but this is a patient plate, and then this is what is your bipolar cautery. Now, if I ask you, what is the difference between a monopolar cautery and a bipolar cautery? The difference between the monopolar cautery and the bipolar cautery is that in the monopolar cautery, the current goes into that particular wound. For example, let's assume that this is the wound where I want to operate. So this is a monopolar cautery. So when I touch this, the current is going to go from this cautery into this particular wound, but the current will be taken and will be picked up by the patient plate, and then it will be taken up back into the what you call as the cautery machine. Okay. On the other hand, when you are talking about a bipolar cautery, in the bipolar cautery, what you have two prongs. Okay. So in the bipolar cautery, you have two prongs. So what happens is that let's assume that this is a tissue. So what you do is you kind of apply the pressure, like you catch hold of that particular tissue between the two prongs. So the current comes in through one prong, it goes through that particular tissue, it is picked up by the opposite prong, and it is basically taken back into the cautery machine. So this is how the bipolar cautery works. This is a basic difference. So we are going to talk about this in depth a bit. Okay. Now, I have a small image to tell you what I just told, what I just explained to you. So here, the surgeon is using a monopolar cautery. Okay, so what is happening is when the current is passing through this particular cautery, it travels through the body of the patient. It's picked up by the patient plate, and it is brought back to the cautery machine. I understand my point. So current came through the cautery machine. Through the monopolar cautery, it entered into the body of the patient, traveled through the body of the patient, was picked up by the patient plate, and then was brought back into the cautery machine. On the other hand, what happened that in the bipolar kind of a cautery, current comes in through the one prong, goes to the tissue, picked up by the other prong, and taken back to the cautery unit. Okay, so this is what you need to understand is the basic difference. Now, in real life scenario, this is how your monopolar cautery looks. Okay, so in the real life scenario, this is how your monopolar cautery looks. So this is the wire. This end basically goes and attaches to your cautery machine. That's fine, nothing major about this. But what you need to actually know, like as a doctor, is this is the cautery handle. Okay, so what is this? This is what is the cautery handle. Now, in the cautery handle, what you need to understand is that there are two buttons. Okay, so one is the yellow button and one is the blue button. Okay, so what is the relevance of this particular buttons? Okay, so this, if at all you press this yellow button, the cutting current is going to flow through that particular cautery, monopolar cautery. And if at all you press this blue button, then coagulation current is going to flow through that monopolar cautery. Okay, I hope you're able to understand this point. So you need to appreciate that there is a difference between the cautery and the current. From the monopolar cautery, we can pass either a cutting current or a coagulation current, depending on what are we pressing. Okay, now what is this blue colored thing? This is like the cautery tip, that's fine. And over here, this is in my hand, this is an insulator. That was the insulator. What you need to understand is what we can do is we can cut that particular insulator. So earlier I showed you that, it was covering the entire tip of that particular cautery. So now what I have done, I have cut that insulator Because let's assume that I want to, this tip basically attaches over here, that's fine. And when I want to use the cautery in the depth, okay, this part should not get touched with any other tissue because it can pass the current to the places where I do not want it to go. Okay, for example, if I'm operating in the deep and there is some vital nerve or a vital artery which is in that particular area, what can happen is if I do not use this insulator, then the current may kind of go there. Okay, so that is just a safety mechanism. And let's say if at all you are superficial, you can keep the length of this insulator a bit more. It's completely up to you. That's fine. So this is okay. This is not that great. It's okay. But what you need to understand is this. Like at your level, you should understand that if you press this yellow button, what current basically goes through is a cutting current. And if you press this blue button, what current goes through is a coagulation current. And this is a monopolar cautery. So if at all somebody shows the image of this particular monopolar cautery, you should be able to appreciate that this is a monopolar cautery device. Now, I don't have the patient plate over here, but it is nothing. It's basically like a sticking plate, like blue colored plate, which has a kind of a silicone thing attached to it. You usually put that particular patient plate on the thigh of the patient so that the current is picked up by that particular plate and taken back into the cautery machine. Perfect. So this was all about the monopolar cautery. Now, let us focus on the bipolar cautery. I gave you the bit of an introduction about the bipolar cautery. Okay, I gave you a bit of an introduction about the bipolar cautery. So as you can see over here, in the bipolar cautery, there are two kind of prongs. Okay, so what you do is that let's assume that this is the tissue which I want to use the cautery on. Let's assume that this is a tissue on which I want to use the cautery on. So you go and, for example, this is the part where the bleeding is happening. So what I do is I go and I press that particular tissue. I have to press it, literally press this particular tissue with my fingers in between these two prongs. And then I press the paddle so that the current flows. So current comes from this prong, it goes through the tissue and it is taken back by this prong. In the bargain, whatever the tissue is in between that, it basically is coagulated. Okay, so the only current which you can pass through a bipolar cautery is a coagulation current. In the monopolar cautery, you can pass a cutting current as well as a coagulation current. Okay, so again, at your level, you need to appreciate the difference in the mechanism between the monopolar and the bipolar cautery. And at the same time, if at all somebody shows you the image of this, you need to know that this is a bipolar cautery handle. Okay, so this is what is called as a bipolar cautery handle. That was the monopolar cautery handle. Now we are going to talk about nasogastric tube. Okay, so if I ask you, okay, first of all, how is this particular thing looks like? So it is just the tube. That is what is a nasogastric tube. You are able to see it on your screens. So let's see it in the real life, how exactly it looks like. Okay, so this is what is a nasogastric tube. I'm pretty sure all of you would have seen this at one point or the other. Now, my question to you is, why do you put this? What is an indication of putting it? So there are multiple indications of putting it. One of the important indications is nasogastric feeding. Okay, so you kind of, let's say if at all there's a patient who is not able to eat food from the mouth due to some or the other reason, you can always put a nasogastric tube and you can start the feeding through this. Or let's say there is a patient who is having intestinal obstruction and patient is having abdominal distension, then you can put this nasogastric tube in order to decompress the abdomen of this particular patient. Now, there are many questions which come from this particular nasogastric tube. So they like to ask you, how are you going to calculate the length? Because every person is different, every person's height is different. So what they're trying to ask you is that, how do you calculate the length? So in order to calculate the length, there is something which is called as a NEX method. What is this NEX method? So you calculate the distance between the nose to the ear to the Ziffy sternum. Okay, so you calculate the distance from the nose to the earlobes to the Ziffy sternum. 5 to 10 centimeters more than that is adequate to reach to the stomach. So the this particular nasogastric tube, then it will be able to reach to the stomach and it will not fall short and it will not coil in the esophagus. Okay, so that is how you calculate the length. That is an important MCQ point as well. So please understand, how do you calculate it from nose to the ears to the Ziffy sternum. Now, another important question they ask you is that, how do you confirm the position? So there are three ways in which you can confirm the position. The first one is the X-ray. Okay. Now, I'm pretty sure that you would have seen a patient with a nasogastric tube having an X-ray. Okay. But let's say if at all somebody has a Foley's catheter. Is Foley's catheter kind of visible on an X-ray that easily? No. So what you need to appreciate over here is that over here in this nasogastric tube, I hope you're able to appreciate this kind of a orangish, brownish line over it. So it basically runs through the entire length of that nasogastric tube. This is what is a radio opaque line. Okay. So this orange brown colored line, it might be a bit difficult to appreciate on the camera. I'm trying, and I hope that you will be able to appreciate once the camera is zoomed. But even if you're not, don't worry about it. Obviously, you will have plenty of opportunities to catch hold of any of the nasogastric tube. Just catch hold of it and just appreciate that there is a line which is running on this particular nasogastric tube. That is what is called as your what is the relevance of that? The relevance is that it is radio opaque. So when you do an X-ray, this particular thing will appear radio opaque. Perfect. So now you can say that, you know what, this nasogastric tube is in the esophagus, or it has reached to the stomach or not, and all this stuff. Okay. So if at all somebody asks you what is the best way, one of the best ways is this, to know the position of the nasogastric tube. Then another way of kind of knowing the position of the nasogastric tube is aspiration and pH testing on it. So what you can do is that you have placed this nasogastric tube with the mindset that this particular tip would have reached to the stomach, inside the stomach. Now what you can do is you can aspirate the fluid from this particular nasogastric tube, and you can check the pH of that particular fluid. Ideally, if at all the tip is actually in the stomach, the pH should be acidic. Okay, so this is what you can say is a very good bedside test. Okay, so this is the best bedside test to know whether the nasogastric tube has been reached into the stomach or not. Okay, this is one thing. Okay, then another one is something which is called as a auscultation while pushing air in the nasogastric tube. This is not accurate. It is not accurate. So this is what is called as a whoosh test, but it is not accurate at all. Not done. Okay. So you would have seen that after putting a nasogastric tube, everybody kind of brings their stethoscope, puts them on the epigastric region, and then kind of flushes around 10 ml of the air from this nasogastric tube with the kind of mindset of hearing that particular whoosh sound. That is what is called as a whoosh test. So this is important. You need to understand the best way to kind of know whether the nasogastric tube has reached to the stomach or not is X-ray. And why? Because it has a radio opaque line running all across. That is the reason. Okay. So there are different markings on it. That's fine. But the length, what is the adequate length and till what length you have to kind of push this particular nasogastric tube is determined between the nose, like by measuring the distance between the nose to the ear to the xiphisternum. Okay. So yeah, that's what you need to understand. Now, how do you insert this particular nasogastric tube? So idealistically speaking, the patient should be, let's say, sitting or at 45 degrees from the bed, or rather basically, you know, like in the Fowler's position, like the patient is basically kind of at the 45 degrees from the bed, or you can kind of put it in the sitting position as well. So in the AIMS exam, they had asked you what is the best way of, not for you, for the NEET PG they had asked, can be asked to you as well, what is the best position to put the nasogastric tube? And if at all the sitting position is in the option, you will go ahead and mark that. If not, then semi-recommend, like 45 degrees, it's kind of okay. Another thing is that the head should be flexed at the neck. Okay. So with kind of head flexed. Okay. So chin should be touching the chest so that the nasogastric tube can enter easily. So that is how you kind of insert the nasogastric tube. Please remember this point. Then contraindications for insertion. If you have already seen my lectures, you would be able to tell me that if at all there is a base of the skull fracture, it is absolutely contraindicated. For example, severe maxillofacial injury, or if at all you suspect that the patient might be having a base of the skull fracture, in these patients, it is contraindicated. Okay, so what you call as base of skull fracture, or let's say severe maxillofacial injury, it is contraindicated to put the nasogastric tube. Perfect. Okay, so that is all about the nasogastric tube. Just to summarize, this is like a long tube. You put it from the nose and it ideally should reach to the stomach. How do you see whether it has reached to the stomach or not, and how do you calculate the length? So in order to calculate the length, you measure the distance between the nose to the ear to the xiphisternum, and then now you know approximately this much amount of the nasogastric tube I have to push in order for this particular nasogastric tube to reach to the stomach. And once it is reached, I want to confirm the position, get an X-ray done, because this has a radio opaque line over it. Now, if at all the patient cannot be shifted for an X-ray and you do not have the availability of a portable X-ray, aspirate the content. Look at the pH. If the pH is acidic, yes, the tip is in the stomach. Then I told you what is the best position to put this, in the sitting position or the semi-recumbent, but the neck flexed. Okay, and the last point was about the contraindication. So severe maxillofacial injury or the base of the skull fracture is a contraindication to put this nasogastric tube. Okay, so yeah, that's all about this particular tube. Now let us talk about this Yankauer suction. What is this Yankauer suction? So what you need to understand about this Yankauer suction is that, okay, forget about this Yankauer suction. Even if you are able to say that, it's a suction which is used in the abdominal surgery, that is kind of good enough. So okay, not that relevant for you as a dentist, but what you need to understand is that let's assume that somebody is operating, okay, or let's say even for thyroid surgery, okay, if you're operating for the thyroid surgery, what's going to happen? Some amount of bleeding is going to happen. Now you need a suction to kind of suck that particular fluid, irrigation, bleeding, everything. So here comes the role of this suction cannula. So what you basically do with this is that this is a tip. This is what is called as a Yankauer suction. Now the tip can vary. Okay, tip can actually vary. So this is what I have in front of me. Okay, but the tip can vary. They can be of different shapes and sizes and all those stuff. That's fine. But the concept is the same. You basically catch hold of the suction like this, and let's say if at all I am operating, or let's say somebody else is operating and I'm assisting that particular patient, the doctor, and if at all there is a bleeding which is happening during the surgery, I can use the suction and I can reach to whatever the places they has to go, and this particular tube is attached to the suction machine. So what happens is that the negative suction is created on this particular tube, and once I put this thing into the blood or whatever the collection or something like that, that fluid is sucked from this particular point and taken into the suction machine. So this is how this particular thing works. This is what is called as a Yankauer suction. That's fine. It's very, very commonly used, or rather it is basically used in every surgery. So that is what is a Yankauer suction. Nothing major, but yeah, it's something which you should kind of know. Now let us talk about Foley's catheter. This is very, very important. So let's kind of have a look at it. So let's first try to understand what I'm talking about. Okay. So, okay, all of you know, why do you use a Foley's catheter? In order to drain the urine. When you want to drain the urine, what you use is a Foley's catheter. Now, Foley's catheter can be either two-way Foley's catheter, okay? It can be either two-way Foley's catheter, where you have two channels, okay? One channel, this one is for the uro bag. So here, what you attach is a uro bag from where the urine is collected into that particular bag. And this channel is used in order to inflate the balloon. So that brings us to this part. This part of the catheter has a balloon over here now. In this particular image, it is in the deflated state. Okay, what is it? It is in the deflated state. But when you put the saline into it, it will get inflated. Now let's have a look at this in the real life. So this is what you are basically seeing. This is what is your Foley's catheter. Okay, so what is this? This is a two-way Foley's catheter which you're seeing. Now this channel is where you are going to attach the uro bag. This is the channel from where you're going to put the saline so that the balloon is inflated. I'll inflate the balloon and I'll show it to you. This is the part where there is a deflated balloon at this point. And this color coding, it's not random. This basically determines the size of the Foley's catheter. These are the basic things which you need to understand. Two-way Foley's catheter, Eurobag attached, a channel to inflate the balloon. That is why the Foley's catheter is a self-retaining catheter. Color coding determines the size. So just by looking at the Foley's catheter, you can tell what is the size of the Foley's catheter. And this is what you would say is a deflated balloon at this point of time. Now, a quick word on how do you put a Foley's catheter. So whenever you want to put a Foley's catheter in any person, obviously the indication is going to be you want to drain the urine. You want to drain the urine. So what you do, you prepare the part of that particular patient. So you properly drape and paint and everything, sterile technique. Then you take a lignocaine jelly. I don't have it in front of me, but what you do is, so there's a common practice that they put the lignocaine jelly inside the syringe. Okay. I'm pretty sure that even you would have seen that. People put the lignocaine jelly inside the syringe, and then through that particular syringe, they put the lignocaine jelly into the meatus. And many times somebody might put a lignocaine jelly, like they will just touch the lignocaine jelly. They will not put the lignocaine jelly at all. This is absolutely wrong practice, because if you do not use adequate lignocaine jelly, the patients may land up into urethral stricture, which is very, very bad. Okay, so let's leave that to the surgeons and the other people. For you, let's try to understand that you put an adequate amount of lignocaine jelly. Now, you insert this end of the catheter completely. You have to be sure that you have reached to the bladder. Now, in case of the females, you don't have to worry, because in the females, the length of the urethra is only 4 centimeters. In case of males, the length of the urethra is big. It is somewhere around 16 to 20 centimeters. So you have to be sure that you have reached into the bladder. So once you have put this catheter till this point, till this junction, now what you do, you aspirate. You try to see whether you have reached into the bladder or not. And once you have aspirated the urine from this particular channel, once you have aspirated the urine, now you can inflate the balloon over here. Because if you prematurely inflate the balloon, the catheter will get inflated into the urethra, which will be very, very bad. So you understand that we have a urinary bladder. From the urinary bladder, we have the urethra, and we want the tip of this catheter to reach to the urinary bladder. Understood. So let's assume that we have put this particular catheter, it has reached to the urinary bladder. I aspirated from this particular channel, and I was able to kind of find the urine over there. So now what I'll do is I will inflate the balloon of this particular Foley's catheter. Okay. So with this, ideally what you use in order to inflate the balloon, ideally we should use distilled water, not the normal saline. Ideally, we should use the distilled water. Okay, in the idealistic world. So now you're able to appreciate this is a balloon and how nicely it has got inflated. So now this particular balloon is going to be, let's assume my hand is a urinary bladder. So this balloon will be over here. Now, even if somebody kind of comes and pulls this gentle tug, it won't come out because the balloon is inflated. It will not come out. And that is why it is called as a self-retaining. Okay, self-retaining. It can be retained by its own self. And you can leave this particular catheter for around 4 weeks. So what is this? This is a two-way Foley's catheter. Okay, perfect. And once it is done, let's say the indication of putting a catheter is over, all you need to do is, so there's a plunger over here, you have to kind of put in adequately, and you have to kind of take out all this particular fluid. You have to deflate the balloon in totality. Okay, once you deflate the balloon in totality, I hope you're able to appreciate the balloon has deflated now. It has gone to its original kind of state. Now you can safely pull this catheter out from the urinary bladder. So once the job is done, now you can pull this catheter out from the urinary bladder. I hope you're able to understand this point. So this is all about the two-way Foley's catheter. Perfect. Now, focus on your screen. What are you basically seeing on your screen? This is three-way Foley's catheter. What is this? This is three-way. So this, in the three-way Foley's catheter, you have 3 channels. One is the balloon channel, which we just saw, which I demonstrated that you can put a distilled water through that. Then I talked to you about the drain channel, where you can attach the Eurobag. I'll attach the Eurobag and I'll show it to you in some time. And then the third one is the irrigation channel. Okay, so why do you want this three-way Foley's catheter? Okay, at the max, you can just understand if at all somebody is having hematuria. What do you understand by hematuria? Hematuria basically means blood in the urine. So if at all somebody is having blood in the urine, there's a chance that this blood can get coagulated inside the urinary bladder. You don't want that. And that is the reason why you start irrigation from this particular channel. So just remember, it's kind of a beyond your scope for now, but what you need to understand, just remember that three-way Foley's catheters also exist, and this is something which you can use in the patients who have blood in the urine. If at all somebody has hematuria, it is ideal to put a three-way Foley's catheter because now you can start the irrigation and prevent the blood from clotting. Okay, so yeah, that's important. Now, I told you na, that this color is not just for fashion, it means something. So it basically tells you what is the size of that Foley's catheter. So you are able to see the different sizes of the Foley's catheter on your screen. So if at all this particular hub is black colored, it means that the size is 10 French. What is this? This is 10 French. So what is a French? It is a outer circumference. Okay, what is this? This is the outer circumference. That is what you need to understand over here. Perfect. So black is the 10 French, then white is, okay, so if at all this is of white color, it means that it is 12 kind of French Foley's catheter. If it is green, it is 14 French Foley's catheter. If at all this is orange, then it is 16 French Foley's catheter. This is red. So red basically means 18 French. So what is this? What is the size of this catheter which you are seeing on your kind of screens on your camera? It is 18 French because this is red colored. Are you understanding my point? Now, then we have like the yellow and the purple. So yellow is basically 20, purple is 22. Okay. Now, at the max, you can remember what is the Foley's catheter which we usually use, normally use. So normally we use in males, adult males, we use 16 French, and let's say in the females, you use kind of 14 French, and the pediatric population, you may use kind of 10 French. Okay, now I inflated 10 ml of the saline, right? But this balloon has a capacity. Okay, the maximum capacity which you can inflate over here is, let's say, around 30 ml also. So this is also written. Okay, so on this particular catheter, you have a lot of information. So here you can, okay, so as I can see over here, it is written 18 French kind of channel and 30 to 45 ml cc. So in other words, this is a kind of Romson's catheter, and this balloon, I inflated just 10 ml, but you can inflate up to 30 to 45 ml. So in the catheters who are like a bit bigger size, for example, this 18 French catheter, here you can inflate more fluid in these particular balloons, 30 to 45 ml. When you will do that, let's say post prostatectomy or something, forget about the details, forget about it. But all you need to understand is, let's say in your life at all, you are catheterizing a small child, 8 years old, let's say a small child, you might use even smaller catheters. So we have the catheters of 8 French, 6 French also, but they do not inflate 10 ml. Okay, it's not a dictum that every catheter has to be inflated. So read how much is the capacity of that. In let's say 8 French catheter, even 3 to 5 ml is kind of more than enough. So please do remember this. It is just a tip so that in life at all you catheterize somebody, you be a bit vigilant about it. 12 French, 14 French, 16 French, 18 French, 10 ml is the standard. That's fine. But in the pediatric population, you inflate a bit less. Okay, now lastly, I was trying to talk to you about the Euro bag. Okay, so what is this? This is a Euro bag. Okay, so this is the Euro bag. Nothing major about this. Here, okay, so a couple of things. Here, this is a Euro bag, and this is how you attach it to the channel. So now you have attached this Euro bag to the channel. Now this catheter is inside the urinary bladder. Urine is being drained from this particular catheter, and it is collected in this Euro bag, and the urine is getting collected in this Euro bag. On the Euro bag, you have these markings, which basically can tell you how much amount of the urine is there so that you can monitor the urine output. Another important thing, if you would notice, this is the valve mechanism over here. Okay, so on the Euro bag, there is a small valve. So just in case, let's say at night or something, if at all the Euro bag is, let's say, turned upside down or something like that, in that scenario also, the urine should not flow back. Otherwise, let's say 200 ml of the urine was evacuated from the bladder, let's say in 2 hours or something like that, and somebody kind of just lifted the urobag like this, and the entire urine basically goes back to the urinary bladder. This should not happen, because in the urobag there is a more chance of infection, and the infection should not go up, and that is the reason why over here there is a valve. It cannot go back. I hope you're able to understand this particular point. Nothing very significant about this, but this is what is a urobag. Perfect. So another important tube is intercostal drain. Unfortunately, I do not have it in front of me, but it's okay. Nothing to worry about. It's just the same simple kind of a long tube. That's it. Okay. So this is how it's kind of appears. You can see it on your screen. So this is what is the intercostal drain. Now the important thing, watch what distinguishes this from the other drains is the end. Okay, so this part of the tube is the one which is basically going into the chest cavity. Let's say somebody has a hemothorax or a pleural effusion or something like that. You put a drain over here. So these are the holes which are present on that particular drain, and they are able to drain the fluid or the blood and all those particular stuff. Now, this is fine. Nothing major about this. This is just a tube which you can put into the thoracic cavity. The more important part is the bag. Okay, so the more important part is the bag. Bag is also different. Again, unfortunately, I do not have it in front of me right now, but it's okay. All you need to understand, let's see, this is what is a urobag. Now, here what is happening is that this tube is coming and the tube is getting terminated over here. And over here, what you have is, you just have a valve. That's it. Okay, but the difference between the urobag and the intercostal drain is that the tube continues till the tip. Okay, focus on the screen. You will understand what I'm trying to tell you. Okay, so focus on this particular part of the screen. What you're able to understand, this tube is continuing till the end. Okay, I've drawn, and now I'll take my marking off so that you're able to appreciate this. Okay, are you able to appreciate? So this is a tube which is continuing till the end. I'll again put my marking. So this is a tube. Believe me, I'm not lying. Okay, so just understand this, that this is what is a tube which is going till the end. At the end of this tube, you have a couple of holes. Okay, and are you able to appreciate this marking? So there's a marking, and this is like a V-shaped structure. So what you basically do is that you put water over here, H2O, water. Perfect. So what are you doing is that this end of the ICD bag is attached to the ICD tube. For a minute, just visualize that. Let's say this is the ICD tube. Now to this ICD tube, what you attach is an ICD bag. Okay, what are you attaching over here is an ICD bag. So once you attach an ICD bag, the tube continues till the end over here. Okay, so the tube continues till the end, and over here what you have is the water. So this is what is called as a underwater seal. Underwater seal. Have you ever heard of this underwater seal? So this tube going and dipping into the water ensures the formation of an underwater seal. So now when I breathe in, and let's say if at all I have a pneumothorax, so the air will come out and air will pop from here. Okay, so I'll use another color. So air bubbles will basically come out of here. But when I breathe, when I breathe out, I'm trying to say, okay, so when I breathe out, the air bubbles are going to kind of pop out of here. That's fine. But like during inspiration or anything like that, the air will not be able to enter into this particular tube because of the underwater seal. So this is the relevance of an ICD bag. ICD bag and the Euro bag are different. I hope you are able to appreciate these points. Perfect. Right. Okay. So this is the ICD bag in one of the patients. What you can see over here, the tube is basically coming, and I hope you're able to appreciate this is what is the water, and the tube is basically going till below that particular water in order to create an underwater seal. Okay. So this is all about the Euro bag and the ICD bag and the ICD and the Foley's catheter, which I wish to convey to you. Okay. Now let us talk about the IV cannula. Now this is one of the very, very important things which we want to kind of use. So right, I mean, let's say if at all there's a patient with a polytrauma, or let's say any patient who has come to the hospital who needs IV fluids, you need to put the IV cannula into these patients. Okay, so in front of you, like on this, like you are able to appreciate that there are 4 IV cannulas. Again, they are of different sizes. Okay, so let's have a look at them. So this is, let's say, so this is basically based on the gauge. Please remember, this is gauge. The Foley's catheter were kind of, the sizes were in the form of the French. Okay, so this is the 18 gauge cannula, green cannula. These are the most commonly used cannulas. There are other sizes as well, but these are the ones which are most commonly used. 18 gauge cannula is something which is used in the trauma patient. So if at all somebody asks you that, you know what, I have a polytrauma patient, what cannula I'm going to use? 18 gauge. Then we have the 20 gauge cannula, which is the pink cannula. So this is most commonly used. Let's say somebody is coming to the hospital and the patient needs IV fluid transfusion. What you prefer to use is a pink cannula. Then which is a 20 gauge cannula. Okay. Then we have a blue cannula, which is slightly smaller. So let's say if at all there's a patient who is elderly, okay, and the patient has difficulty in finding the IV line. In these patients, what you can use is this blue cannula. And in the pediatric population, what you prefer to use is a yellow cannula. Okay, so these are the most commonly used cannulas in our day-to-day practice. We will talk about the other cannulas as well, but yeah, that's fine. So now what I'll do is I'll just open one of the cannulas and then we can have a look at this. Okay, so let's open the green cannula. So this is how you kind of open. This is a sterile cannula. This is how you open. And now once you want to kind of insert it or something, obviously you kind of take it off. Nothing major about this. So let us kind of go through the parts of this particular cannula. Are they relevant from the clinical practice? No, but let's kind of go through what are the different parts. You might, like, few of them have definite kind of relevance. So let's talk about that. So once you kind of take this, there is a cover. Okay. So let me just take these cannulas out of the frame for now. So this is what is the green cannula, which is your 18 gauge cannula. Okay. Now, what is this? This is what is the cover, which is basically like inside this, what you have is the stellate and the cannula per se. Okay. So this is what you use. I am holding this particular cannula from the wings. Okay. So from the wings of the cannula, I'm holding this particular stuff. Okay. But kind of, let's have a look at that. I'll tell you what is this. So this is what is the needle. Okay. What is this? This is what is the needle. And this is what is the catheter. So what you need to understand is I want to put this cannula into somebody. Okay, so how do you kind of put that? So, okay, let me just kind of tell you the parts and then I'll tell you how do you put that. Okay, so in order to just show you the parts, I am just taking this off. So are you able to appreciate this? This is what is the needle. Okay, so this is the sharp needle which you have, and this is what is the catheter. So this is like a plastic. This is completely flexible. So once you put the IV cannula, all that is inside is this flexible silicone tube. That's it, nothing major. Okay, so let me put this particular thing back. Okay, so I've put this particular thing back. Okay, now, so we talked about the needle, we talked about the catheter per se. Then what we have is, we have the kind of valve and the wing. Okay, so let's not cover everything. So this is the wing of the catheter. This is the injection port cap. Okay, right, and this is the lure lock plug. Okay, so this white colored thing, what you're seeing, this is a lure lock. Okay, so this is lure lock. It means you have to kind of rotate it in order to kind of take it off. So this is what is your plug at the end of it. That's fine. Then you have these wings. So you catch hold of the cannula with your thumb at this particular lure lock, and then you have this 2 fingers at the wing. Okay, so now what you basically do with this is, let's assume that I want to put a cannula into this particular patient. This is the arm of the patient. Okay, so what I do is I apply the tourniquet, and so I apply the tourniquet and I kind of, what you call as clean that particular part. Okay, so let's assume that you want to put the cannula over here. So, okay, there are a lot of hairs. If at all your patient also has a lot of hairs, you can always trim it. Otherwise, you might find it a bit difficult to kind of put the cannula. So once you have kind of trimmed the hairs and everything, what you can do is you can apply a tourniquet over here, and you ask the patients to kind of close and open the wrist again and again. So what this is going to do, this is going to make the veins prominent. So let's assume that this is the arm of the patient and this is the vein which you are having. So now the vein is prominent in front of you. So what you want to do is I'll show it to you over here. So the whole point about this putting the cannula is that you want to gain entry into the lumen of the what you call as the vessel. Okay, so let's assume that this is the vessel. When you are wanting to put a cannula, what you want is that your needle should enter into this particular vessel, and then you need to be parallel. Because if you don't become parallel at the right time, you are going to counter puncture, which you don't want. Okay, so that is the problem. So what you need to do is you need to gauge it. You need to go and you need to enter the one part of the lumen of the kind of vessel, and now you have to be parallel and you have to kind of go in. Now, if at all you are properly inside that particular artery, what is going to happen? The blood will come and it will get collected over here till here. Now what you do? You compress the vessel distally and then you remove this metallic kind of a needle. Okay, so you remove this metallic needle. Okay, so you compress the vessel distally and you remove this particular metallic needle from that particular cannula. Okay, so this is how you insert a cannula. Again, it's easier said than done. Obviously, once you practice this on a couple of patients, you will be kind of better off on it. I'll just explain you once more. So what you do is, this is the wing of the cannula, this is the needle, this is the cannula per se, this is the luer lock, this is the hub. So once you want to put this particular IV cannula into any particular person, what you do, you gain entry into the vessel. Now you do not want to counter puncture that particular vessel, so you just gain entry into that lumen and then you try to be parallel. You go in. Once you are adequately into that particular vessel, the blood will come over here and now you know that you are inside. Now what you do is you okay, so before removing this, compress the arm distally, because if you don't, once you remove this particular needle, the blood will start to come from here. So you remove this particular needle and you keep the needle outside, and this luer lock, you apply the luer lock on the tip of this. Okay, so you apply this particular luer lock, that is a screw mechanism, you kind of apply over the tip of it, and now you fix this particular cannula to the surface. This is how you kind of put it. Yeah, that's what it is. Okay, so a bit of a practical application. Obviously, nobody's going to ask you this in your MCQ exam per se, but yeah, they might ask you in your table viva or something like that. So that's okay. Perfect. So this particular needle is thrown away, and inside the body or inside the vessel, what you have is this flexible silicone kind of a tube. That's it. Perfect. Now, I talked to you about the different sizes, right? So let me just bring all the other cannulas into, and now you discard this into the sharp pin. Okay, so you need to dispose this off properly. So this is what is your green cannula. That's fine. Okay. And what is this? This is what is an injection port. Now, what you need to understand is that many of the sisters, or I don't know whether you give the injection or the sisters give the injection, but many times what they do is they give the injection from this port only. Okay, they basically remove this luer lock and then they give the injection through here. No, this is basically ideally used for giving the crystalloids, or let's say the blood transfusion. That is what should be given from this particular port. But if you want to give an injection, this should be given from this injection port site. Why? Because when you push it, you might push it with the force, and if at all you push it with the force from this, the cannula can kind of like rupture that particular vessel. But if at all you put it from here, even if you put it with the force, it is going to hit the base of this and it won't ultimately rupture because the pressure will not get transmitted into those small vessels. I hope you're able to appreciate. So just teach to the next sister you kind of come across. If at all you find somebody who is giving the injection from here, take a chance to explain them why it is ideal to give the injection from the above injection site port rather than this. This is something which you can use when you want to transfuse the fluids or when you want to transfuse the blood or something like that. You can use this particular port. Okay, so that's all about this. Okay, so this port is for the transfusion of the crystalloids or the blood or something, and this is the port from where you put the injection. Okay, so that's whatever the injection you want, whatever the drugs you want to give, you give it from here. Okay, now let me just bring all the IV cannulas which I have in the picture again. So this is what is your 18 gauge cannula. Then this is what is your 20 gauge cannula. This is 22 and this is 24. These are the commonly used cannulas. Okay, so let's kind of have a look about them first. Okay, so green one is your 18 gauge cannula. This is used for standard trauma in the surgery. So for example, the blood transfusion, for the CT contrast, general surgery, this is what is used. Another important thing which they ask you is what is the rate of flow. Okay, so please understand it is 90 ml per minute. Okay, forget about these parts. Okay, so just remember it's easier, 90 ml per minute. Okay, so what is the rate of flow? It is 90 ml per minute for the green cannula. Understood? Perfect. Now, what is this? This is what is the pink cannula. This is 20 gauge cannula. Here, this is used for general adult wards. For example, somebody suffering from dehydration, somebody suffering from vomiting, somebody wants some IV antibiotics which has to be given as an infusion. What you insert is a pink cannula and the rate of flow is 60 ml per minute. Maximum rate of flow. The blue cannula, that is the 22 gauge, this is 30 ml per minute, that's fine. And this is used when you have a difficult vein. For example, an elderly, or let's say somebody who had received chemotherapy in the past. The veins are very, very small and brittle. Chemo or the radiotherapy or something like that. Then yellow, 24 gauge. This is used for pediatric population, infants, toddlers, very fragile veins, around 15 ml per minute. Okay, so please remember the rate of flow as well. And at the max, you can remember about this gray, not used in day-to-day life. But yeah, if at all somebody has a major trauma, a major surgery, you may use this, but frankly, not that commonly used. It's quite kind of thick. Leads to the rupture of the vessel most of the times. But yeah, the advantage is that the flow is kind of like 180 ml per minute. Okay, so if at all somebody needs a rapid infusion, then you can put a gray cannula. But largely, even if you remember these four, you will be good to go. So these are the 4 IV cannulas. I've tried to demonstrate to you how do you put it. Try to have a look at a couple of videos on the YouTube as well. And if at all you get a chance to put this particular IV cannula on some patients, under supervision, under guidance, try to do that. Observe a couple of times, observe 5 to 6 times. Then you can maybe start putting these IV cannulas and fine. Nothing major, but it's fun to do it for the first time. Yeah, that's all about the IV cannula. Now, let us talk about the other drain. Okay, so what is this? This is what is a Romo vac drain. And what is this? This is a Me vac drain. Okay, so let's try to understand that. Okay, so let's kind of remove this particular drain. This is what it is. Okay, so are you able to appreciate this spring-like thing? Okay, so that is why it is called as a like vac. Why? Because once you kind of press this and when you apply the knob to it, it creates a vacuum. Okay, it creates a vacuum. It has that particular pull. Okay, so let's have a look at it. What else comes in this particular package? So this is, okay, the drain per se. Okay, I'll tell you what all these things are. There's another tubing and there is one more tubing. Perfect. Okay, now such a big drain is something which we put in the patients when you perform mastectomy. So what is this? This is a Romo vac drain which you put in the patients after performing a mastectomy. So what you do is the ones you have done, okay, what is the purpose of putting any drain per se? So the purpose of putting any drain is in order to prevent the post-operative secretions. For example, the seroma. If at all the patient develops a seroma, that seroma should drain into should get collected over here and should not get accumulated at the operative site, because if it gets accumulated at the operative site, it can create some complications. It can create infection over there and all those things which you don't want. Okay, so what you do is, I'll talk to you about the mastectomy first. Okay, so what you have done a mastectomy. Okay, so it's steward incision, whatever. So this was the breast area and all the stuff. Okay, so very, very bad drawing, but I'll kind of draw it again. Just give me a minute. Okay, so let's say if all this is the woman in whom we have performed the mastectomy. Okay, so we have performed the mastectomy. So this was the incision which was given, the breast tissue was removed, the axial lymph node dissection was done. So all these particular things were done. Now what you do is, now before you close that particular wound, what you do is you put in a drain from this axilla, you put in a drain. So are you able to appreciate this? Okay, this. So this is always closed. Why? Because this is such a sharp thing. So this sharp thing is used, for example, this is, let's say, the skin of the axilla or something like that. Okay, let's assume that this is the skin of the axilla. So this is able to kind of penetrate through the skin easily. Now let's say if at all this is the skin of the axilla, this basically comes out, and now what you do is you cut this particular part, and that's fine. Okay. So what happens is that these serrated parts are inside the axilla, and